Welcome to Health or Consequences. This is Commonwealth Beacon and Mass Inc.'s monthly health policy and politics podcast for Massachusetts. My name is John McDonough. I'm at the Harvard Chan School of Public Health. I'm joined by my co-host, Dr. Paul Hattis from the Lown Institute. And we have a special guest this month. His name is Dr. Zirui Song. He is a researcher at the Harvard Medical School. He is a physician at Mass General Hospital and Mass General Brigham. And he is a leading researcher right now on all manner of topics that are of compelling interest to people who pay attention to health policy in the United States and in Massachusetts. We're going to be discussing two in particular today, his research and learnings and thinkings about primary care nationally and in Massachusetts. And we'll also talk about private equity and its role, because he's done some cutting edge and important research on the impact of private equity in medical care and our healthcare systems in the US and Massachusetts. So welcome, Zirui.
Thank you so much, Professor McDonough and Dr. Hattis. It's wonderful to be with both of you here.
Pleasure to have you. And I will ask I'll ask the first question. So for people who pay attention to US medical and health system research, you are already for many a go-to source of knowledge and insights. For the 99.9% of everyone else, can you tell our listeners a little bit about your story and who you are?
Thank you, John. I'm a primary care physician at Mass General, where I see patients in primary care clinic about 2 half days a week and attend on the inpatient teaching service with our residents about 4 weeks each year. Outside of my clinical work, I was trained as a health economist in the Department of Healthcare Policy at Harvard Medical School, where I've been on the faculty for about the last 8 years. Here, I do research and teaching in health policy and health economics around provider payment, health insurance issues, quality measurement, and as we'll talk about today, financial incentives and primary care and ownership in the delivery system. I also spend a lot of time in teaching activities. I run the health policy course for first-year medical students with several colleagues for the past number of years here, and teach a similar class for the Mass General and Brigham medicine residents who are interested in health policy each year as well. I also do some teaching for the medical school for external audiences, those from large employers and from other countries who come to campus to learn something about health policy and health economics.
Zirui, really add my warm words of welcome and then dive into you with a few questions about primary care. You know, what are your strong areas of interest, and something you actually with Professor and Dean Sandro Galea, you've recently written a JAMA publication-related editorial on, tied to the most pressing issues affecting primary care practice in 2025. Can you enumerate some of those concerns, both from the provider's perspective and the patient's perspective, if you would?
Sure, Paul, absolutely. And thank you again for your interest in this topic. Nationally, primary care is still struggling after many years of long-standing struggle. And the struggle involves both financing challenges in the underpayments of primary care services and the underfinancing of our clinics all across the country, both family medicine and internal medicine and pediatrics and now geriatrics, as well as a workforce challenge that compounds the urgency to do something about the financing. All of this has exacerbated an access, really crisis, I would say, in the American public, where roughly 1/3 of US adults report not having a usual source of primary care. And that's grown quite a bit over recent decades. And as the population ages and more people confront chronic disease and multiple co-occurring chronic diseases, the value and the necessity of a primary care clinician to coordinate and manage multiple pieces of the delivery system in a person's lifelong journey only increases. And so just as the demand and need for primary care grows as the population ages, the supply of primary care clinicians continues to dwindle, now to a level where we have less than a third of primary care residents in internal medicine residency training programs who have declared and mapped into primary care tracks, finding it appealing enough to actually stay by the end of their third year. The majority now of even primary care residents choose a subspecialty career or a hospital medicine career after residency for very logical, rational, and justified reasons. And so the field has not, it wasn't always either, but it has continually to not be attractive enough for the majority of our trainees to stay in the field. And at the same time, there is a growing off-ramp of exits from traditional traditional primary care practice, rather, into more free market models of practice, including concierge primary care, direct primary care, models of practice that are a little more detached from the traditional delivery system, the integrated delivery system or the large group practice, and in some cases detached from health insurance completely, where existing long-time primary care physicians are finding more autonomy and more restored joys of practice and more face time with patients and smaller panels outside of the traditional system. So the exits are growing, the entries are slowing, just at a time when we need more supply for a growing demand for primary care. And that is the national crisis that we face.
Well, let me drill down a little bit more, or at least allow you to, from a state of Massachusetts perspectives, because as you know, we have a high-level state task force created by our legislature that's right now focused on coming up with some solutions to the primary care crisis. Other states have waded into these waters as well. Do you see the outlines of a solution for our state in particular? And is it really within the power of our own state to devise a solution or devise at least some approaches that can make things a lot better?
Yes. I think states are not only the laboratories of innovation these days in health policy in many domains, but also, particularly on an issue like primary care, states have a unique vantage point because states take care of populations not just for their health, but for many other needs, whether it's food assistance or transportation or education or other social services. States have a large purview there. They're an incredibly important part of the public's journey. So to think about and work on primary care from a state perspective makes a great deal of sense. Also, obviously, states manage Medicaid programs, which are incredibly important for disadvantaged and low-income populations, and specifically their primary care and continuity of their connections with the healthcare system.
So what should we do? What should our state be doing right now?
In Massachusetts, as many other states have experienced, primary care clinics are relatively underfinanced and have been for many years and decades. This is in part due to a national issue with the fee schedule, where the Medicare fee schedule, which essentially values the worth in monetary terms of primary care services, notably an office visit, on a scale that disadvantages those services relative to procedural care. A quick example would be the most commonly billed code in America of 15, 20, 25-minute office visit with an established patient is valued at roughly 1/10 the financial value of a procedure, like a cataract removal, just as one example, that takes basically about the same time. And so that reality of the what you might call distortions or inequities in the valuation of medical services has been longstanding since the 1980s and plays a large role in explaining the underfinancing of primary care clinics. And it matters actually a little less whether the clinic is largely serving a private insurer patient base or Medicare patients or Medicaid patients or a mix. Essentially, that distortion in the valuation of medical services carries through all of the fee schedules of all of these public and private payers. And so that longstanding reality is fixable. There have been roughly 40 years of efforts to try to fix that or adjust that or bring a little bit more parity between non-procedural and procedural services within the fee schedule. But that's a struggle at the federal level because of procedural reasons and the way that the fee schedule is set and advocacy from many sides of the debate. So the state, any state, doesn't have an easy time overcoming that. But what states can do is think about primary care in new ways. Our predecessors, from a Massachusetts perspective, our predecessors in other states who have tried to do something about investing in primary care or getting more dollars into primary care have started to think this way, such as putting more money into primary care off of the fee schedule. So no longer just toggling the fees up or down for primary care codes, but rather thinking about a population being managed and attributed to a primary care clinic, and then giving that primary care practice a certain amount of per person per year or per person per month fees to try to manage all of the care for that person. Very analogous to how we think about payment reform or alternative payment models or value-based payment or capitation, to use an older word. And that type of approach on top of the fee schedule spending allows primary care clinics to simply get more money into the door. And with that, the primary care practice, in theory, has the ability to pay the providers more, buy more things that it needs, whether it's physical infrastructure like an electronic medical record, or whether it's human resources, hiring allied health professionals to do medication reconciliations, to potentially call patients at home, to manage their care, case managers, for example, or social workers. And that's an important way to augment the functions of the primary care clinicians, to also protect their bandwidth a little bit, to share in the work, and to do team-based management of a patient, particularly one with chronic diseases, multiple chronic diseases. And so many states have gone towards that approach. Some have done this in a multi-payer way. Some have focused on commercial insurers and perhaps are moving into other populations. Rhode Island was one of the first to think about this and move in this direction through state-level policy. Massachusetts, obviously, we've had several years of discussion on this front, which we can get into. California has recently set its target for primary care spending. Many of these states have started out with a target for primary care spending being a certain percentage of total healthcare spending devoted to primary care. Colorado, Oregon, Delaware are other states that have legislatively moved in this direction. And so states can do a lot by reformulating how they think about primary care. And the most innovative, one might argue, or the farthest departure from primary care being simply part of the fee schedule is probably thinking about primary care as a public utility. That would probably be the largest departure, where we think about primary care as a public good, as something akin to when you turn on the faucet in the kitchen, water runs. You expect water to run. When you flip on your light switch, you expect electricity to be running. Analogous to that kind of public utility, a state could think about primary care as such a public good. Now, obviously, it's very different in nature. It's healthcare services at the end of the day. It's got providers and patients, and there's a physical interaction here that is countable, measurable, and you want some accountability around the quality. So it's not just water and electricity, but fundamentally thinking about primary care as a public utility allows a state or a self-insured employer or any entity responsible for paying for care to lift it out of the fee schedule in concept. And then that opens up possibilities for financing, for dispersing the financing, for potentially even organizing the care. Although we have to be very careful and respectful of the boundaries and the rules and the culture of organizing and paying for primary care that our insurers and health systems have built over the years. Those are not easily disrupted, and we should respect those even as we make reforms.
Let me ask you this final question, because we want to move on to other things. Whether we move some ways closer to this public utility model, or just like other states, at least increase the resource flow into primary care. One of the concerns I know that's been raised is that a lot of physicians like yourself are employed by hospital systems, and that could well be an impediment to some of the goals of the policy changes here. And any thoughts you want to reflect on, tied to what I've just said?
There's an age-old debate between consolidation and integration in the delivery system and competition and autonomy in the market. And there are pros and cons to moving in both directions. Consolidation and integration allows primary care physicians to be embedded within colleagues from the specialties, to be embedded closer to hospitals, potentially where, especially in the old days, they would still round on their patients who get admitted. And my colleagues at Mass General, many of them still do that. It's incredibly admirable. It's a wonderful way to maintain continuity of care from the inpatient side to the outpatient side. And of course, you share in the electronic medical record. You can see everybody's notes. You can read all the image findings without having to fax paper around. You can communicate easily on the same pager system. Malpractice costs are covered on a group basis. So there are obvious and clear and historical advantages to being part of a larger group. And of course, if you think about the longstanding negotiations between providers and insurers in general, well, it's long been advantageous for providers to be larger. They simply have more market power and can garner higher RVU conversion factors, meaning the dollars per service unit valued within the fee schedule. And that's been true for many decades. But of course, now increasingly we see that consolidation and integration has some downsides too, notably what many physicians on the front lines would characterize as the corporatization of healthcare delivery, where they feel like they've lost their autonomy, they've lost that sense of being able to do what they feel is right for the patient, unencumbered by rules and regulations or technologies or reporting requirements or even just the EHR or prior authorization form in front of them, where they feel like they are a cog in a very large wheel, where they feel like their voice is not heard as much or drowned out by all of the other things in the wheel. And that is an increasing complaint that we not only hear locally in Massachusetts, but we hear across the country from primary care clinicians on the front lines. But if you move all the way to the independent, autonomous, everybody on their own model of healthcare delivery, you'll also have to struggle with and contend with downsides there, which is how do you refer patients around? How do you keep track of who did what? Who do you know? Who have you worked with? Is your referral network for a primary care clinician really the optimal one for a patient, or simply the one that you've built and known over the years? What if you need a really subspecialized service? It would be harder to get a patient into a large system when you're outside of it. So there are some operational downsides to being independent, but what are the upsides? Well, being independent allows you to have your autonomy back. It allows you to dictate your workday in ways that you probably cannot in a larger practice. It allows you to figure out exactly how much you want to work with health insurance, with some physicians declaring with their own, voting with their feet, that they don't want to work with health insurance at all. And they're going to be completely outside of the insurance system for primary care. All the way to those who still work with insurance and charge a retainer or membership fee. And that autonomy is really appealing for many physicians, particularly as they maybe approach the later stages of their careers, where they could wind down the number of days or sessions of practice much more easily. They could choose to see patients at home and do home visits, which is really enjoyable and a part of the art of medicine that is increasingly lost in recent decades, where they could give patients much better access and find a lot of satisfaction for both they themselves and their patients that was not attainable in the traditional large group system. So somewhere in the middle, you would imagine, is a sweet spot. Either extreme seems to have a bunch of really important trade-offs that we would have to work through as a society and from a policy perspective. And I don't think any state has really finished this journey yet, though some have taken the initial steps.
So let's look at your work on private equity in healthcare. So we know that over the past 15 years or so, private equity financing and ownership has become a major force in U.S. healthcare and medical care. Could you briefly describe what we mean when we say private equity and why its presence has become so controversial?
Yes, certainly, John. If we were talking about this 10 or 15 years ago, the answer would be a little easier and more straightforward, because when private equity firms began investing in healthcare delivery, probably around the mid-2000s, starting with hospital acquisitions, the model of acquisition tended to be a leveraged buyout, meaning a debt-financed acquisition, where the private equity firm raises funds through its investors and puts a little bit of funds in from itself, but largely borrows money from either a bank or another type of lender to finance the acquisition price of a hospital or nursing home or healthcare facility. In that type of model, the responsibility for paying back that debt with interest falls on the acquired entity, not the parent firm that did the acquisition. And so the acquired entity, let's call it a hospital, would face some additional debt on day one of the acquisition. It would have to continue operating, hopefully generating a margin for the parent firm to keep operations going, and at the same time, enough margin to eventually pay down this debt and the interest on it. Then, after a few years, the range is actually quite wide, from about 3, I would say, for physician practices to maybe roughly 10 or even more for hospitals. There would be a sale of the acquired asset, where the acquired facility would then be sold, often to a second private equity firm, which is common in physician practices, or to a potential other type of corporation. It could also go public and ask the public for financing through the stock market. But there would be some kind of second transaction where the initial owner would kind of let go or exit the investment. That kind of model was perfected in other areas of our economy, including manufacturing, consumer goods, the service sector, through the 1980s, the 1990s, the early 2000s. And it really took about 25 years before it was brought to healthcare. And one of the reasons it was seen as advantageous is that the financial risk that the parent firm owns when making that transaction decision is actually quite minimal. Often through management fees, for the privilege of managing their investment dollars, the investors pay fees to the firm. And for the privilege of being acquired and owned and managed by the firm, the acquired entity often, not always, but often also pays management fees to the parent firm. So the parent private equity firm can basically offset its own risk in the acquisition very quickly, just through management fees, if it waits 12, 18 months after the acquisition. Even if the acquisition does not do well, eventually it could technically walk away on the plus side of the ledger. And there have been obviously many cases of that, including here in our own state and many other states with hospitals. And so that would have been the answer. That's pretty much the easy answer. And I'll just very quickly highlight that the harder answer nowadays, now that we're about 2 decades into the private equity journey in healthcare delivery, is that the model of acquisition has really diversified. It's no longer just this straightforward leveraged buyout where you get 70 to 80% of the acquisition price borrowed through a bank or a lender. It's now that some acquisitions involve very little borrowed money. Some are involving borrowed money from a second private equity firm as opposed to a bank. The acquisitions are now diversifying across the delivery system, not just in provider and frontline delivery, but also in technologies, in new drugs and development, in much more of an earlier stage venture capital type of investment. The share of the acquisition price that's actually borrowed money versus existing dollars, so debt versus existing equity, is quite variable. In many physician practice acquisitions, it's quite little debt and a lot of equity. And the exit strategies have really diversified too. For example, our colleagues have found in physician practice acquisitions, over half are sold to a second private equity firm within 3 years. So the handoffs are quite quick. And hospitals were just starting to learn what happens when a second hospital buys the hospital from the first private equity owner. And the second owner could be a second private equity firm, or it could be a non-private equity for-profit company. And there seems to be some differences there in what happens to the hospitals. So the picture has gotten much more complicated. But the easy answer would have been the leveraged buyout.
So over the past 5 years, you have produced some groundbreaking research looking at some of the questions about, so what actually happens to patient well-being, patient welfare, and to costs, quality of care and costs, when a hospital, a physician practice, or others are taken over by private equity. What have you learned from your research?
Thank you, John. That's very kind of you. With many wonderful colleagues now across the country, I've had the privilege to work on these questions. I just want to highlight many of these studies have been led by prior students or junior colleagues, including Joseph Brush at the University of Chicago, Yashaswini Singh at Brown University, and Sneha Kannan at the University of Pittsburgh. They are three among many colleagues who have led a lot of the work on this subject. What we've generally found in this literature, including with colleagues at OHSU, at Hopkins, at Cornell, Penn, and elsewhere, is that on the financial side, these private equity acquisitions are pretty clearly linked to increases in prices, profitability of hospitals, the asking prices reflected through charges, as well as the transacted negotiated prices that depend on market power. Both types of prices rise, and quantities also tend to go up, but in some situations, whereas in other situations, quantities of care have a hard time going up after acquisition because staffing gets cut. There are fewer hands on deck, and it's actually potentially harder to generate a lot more volume. But essentially on the economic side of prices multiplied by volume equaling revenue, we see that both the price lever is turned up and the volume lever, when it can, is turned up. On the clinical side, what we've learned is that for patient outcomes, it looks like patients on average experience harm. In the nursing home setting, before we did our work on hospitals, our colleagues at Penn and NYU found a roughly 10% increase in mortality in the Medicare population in nursing homes acquired by private equity firms, explained probably through reductions in staffing. Then on the hospital side, we found a 25% increase in preventable adverse events after patients are admitted. That was driven by bloodstream infections, surgical site infections, and falls relative to the control group. We believe that was also largely through cuts in staffing. We also found an increase in referrals of higher risk patients to other hospitals right after acquisition, which meant that the patients left in these facilities or hospitals were on average a little lower risk. And among lower risk people, you would assume or you would hope that complications go down, but they actually went up. So that was quite concerning. Thankfully, inpatient mortality, that mortality immediately at the point of care, did go down because the patients were a little younger and lower risk. That made a lot of sense. But with fewer hands on deck to take care of patients in a highly labor intensive hand-to-hand type of work at the bedside, complications going up were still concerning. And most recently, we found a roughly 13% increase in patient mortality in emergency departments after these private equity hospital acquisitions. And that was fairly clearly tied to 16 to 18% reductions in staffing cuts, both through staffing expenditure reductions as well as total FTE cuts hospital-wide of about 12%. So roughly same order of magnitude. And so we believe that for patients in at least hospitals and nursing homes, there are some concerns that private equity firms and our policymakers have reason to pay attention to, as well as patients and families and frontline clinicians. On the financial side, it seems like there are various strategies for improving profitability and revenue. And in physician practices and other outpatient sites, the evidence is still in infancy, but continues to grow. We know less about what happens to quality of care in those settings, given that mortality and patient harm is simply less common. People tend to walk into clinics and walk out of clinics. So questions there around the appropriateness of services or the value of the care remain largely unanswered. But the profitability side, the economic side, still is quite clear that these acquisitions lead to higher prices and, in many cases, increased volume.
So understanding, and we hear you, that you're not making a categorical condemnation of private equity in medical care, but at the same time recognizing there's a lot of room and rationale for concern. There are a lot of states in particular who've been going in and trying to regulate this to create some better protections. Massachusetts did it this past January and is one of the states in the lead on this. What do you think is most necessary for public policy to do in response to this right now?
Transparency seems to be the first step that many states have taken or are currently debating taking. And that makes a lot of sense because for many, many years, the transactions within the delivery system were simply not known to lawmakers, to the public, to journalists, to any watchdog agency. In many cases, the transaction amounts were below the federal threshold for mandatory reporting. And the threshold sits at around $120 million for a transaction today. Many states have state laws that act in conjunction with that federal threshold, so that's not the binding one all the time, but the federal threshold gives you some sense of how large the transaction amount has to be for the public to know about it. Well, many physician practice acquisitions, your practice across the street could be acquired and then sold 3 years later without you knowing about either transaction. So I think many states have taken this initial step of just putting a little more sunlight onto these transactions, getting the information out there. In Massachusetts, we are quite lucky to have several state agencies participate in this collaborative effort. We are blessed to have an agency that has data like CHIA, and we're fortunate for many thoughtful colleagues who at the Health Policy Commission watch over these transactions and think through the implications for patients and for clinicians on the front lines, as well as for the delivery system as a whole. Many states do not have that kind of infrastructure built to both study, think through, and then potentially manage these acquisitions. So Massachusetts is in the lead in part because we've set up this infrastructure through prior state legislation to have the eyes and the ears on a topic like this. Many states are trying to do something beyond transparency as well. In Massachusetts, we did this as well. And in our Massachusetts state law from this early this year, we have we have a stipulation that forbids the sale of on-campus, main campus real estate from hospitals to private equity, often private equity-owned real estate investment trust. That's an example of a policy choice that is beyond transparency alone. So trying to protect patients and clinicians on the front lines from a knowable harm that's been demonstrated, that's been studied. And many other states have tried to do this. Oregon is an example of doing this in the physician practices space, using the corporate practice of medicine statute as the basis for more actively managing private equity acquisitions of physician practices. California recently passed a couple of laws, both in the spirit of transparency and in the spirit of more active oversight. And many other states, Pennsylvania currently is in a fairly deep discussion about what to do. Connecticut, Rhode Island, or other states that have confronted and talked about this issue. And so in each of these states, the response has relied on the infrastructure in those states. Sometimes the agencies differ, sometimes the state body that's going to have oversight over these transactions differs. But I think all of these states are rowing in the same direction. And that is to first know about the transactions, and the second is to try to think through what guardrails are appropriate to prevent patient harm, to prevent clinician harm or burnout, or otherwise restricting physicians' abilities to make their own decisions or even move around practices. And finally, to protect taxpayer dollars and public resources, given the price increases that are obvious.
Zirui, as we wrap up this conversation with you, really a very thoughtful one on some of your thinking about primary care and private equity and some of the research that you and colleagues have done, what can we expect your focus will be for the next year or two in a research sense?
Well, thank you, Paul. On the subject of something like ownership changes or private equity or corporatization in general, I think we have a quite fundamental question still ahead of us, which is how do you get more of the good and less of the bad? When the evidence base shows you that clearly there's potential for harm, but the clinician or delivery system or provider community tells you, or when lawmakers hear from constituents that private capital is really needed in many situations, that without Medicare raising its prices or Medicaid raising its prices, or without the ability to negotiate for higher prices from commercial insurers, a healthcare facility or a practice might really need private capital from somewhere in order to hire people or to buy things or to continue operations. So it tells you that shutting off the flow of private capital probably is impractical and probably will also involve some harm in cases where private capital could do good with the appropriate guardrails. So I think an incredibly important and salient policy question ahead of us is, how do states and the country as a whole, the federal government has also approached this issue. Bipartisan Senate Budget Committee worked on this with a large report. HHS issued a large report. The FTC has worked on this issue as well. How do federal and state policymakers construct the appropriate guardrails for private equity or other sources of private capital to come into the delivery system, but through the pursuit of margins and profits, not harm anybody? First, do no harm, to protect patient well-being on the front lines, to protect clinician well-being, to not disrupt what is sacred in the healthcare system, while still having an opportunity to walk away with a margin for its investors and itself. Compared to many of our European neighbors, we lack many of these meaningful guardrails. This is not to say all these guardrails work all the time either. There are compelling examples in other countries where well-intentioned guardrails may not have had the intended effects, but at least there have been efforts to try to construct useful guardrails, and we haven't done so much of it here. And you might imagine a world where if you construct guardrails that make private sources of capital not want to come into the healthcare system anymore because it's just so unappealing, because there's just so much regulation, or there's just no opportunity to make a profit, then maybe that's overdoing it. But we at least have to try to protect patients a little better on the front lines than we've seen in many of the examples where heavily debt-loaded facilities are then renting back their own buildings because their land and real estate have been sold from underneath them, where they're lacking supplies, they're lacking resources, there are staffing cuts, and patients are really lingering on the front lines. So I think that's the big policy question. Many colleagues across the country continue to work on this. I'm privileged to be a part of that general effort. I think very quickly on primary care, there's a lot to do about the workforce, and there's a lot to do about the financing challenges. There are many ways to get dollars into primary care, and I think we're still continuing to study the effects of these different methods of doing so, whether it's on or off of the fee schedule.
So Dr. Zirui Song, Mass General Hospital and Harvard Medical School distinguished researcher, thank you so much for your time. This has been a very illuminating and informative interview with you, and good luck in your research, good luck on your teaching and your patient care and everything else. Thanks for being part of it.
Thank you, John. Thank you, Paul.
And on behalf of Paul Hattis, thank you to our listeners for joining us, and we'll be back again next month with another edition of Health or Consequences. Thanks, everybody.